Okay, this is different. But anyway, I'm glad to share this session with you all. I think all of us already have performed some of the PLC reconstruction. And to improve the PLC reconstruction, we have to know about the anatomy of the PLC complex, which consists of tendon, muscle, ligament, and capsule. And it's mechanically divided into the static stabilizers and dynamic stabilizers, which are primary or secondary restraint. And most of us will concern about the LCL or FCL, which is the fibular collateral ligament, and popliteus tendon, which are static stabilizers. And and the popliteofibular ligament, which is the secondary restraint. And the instability actually are vectors for the instability between the femur and tibia with fibula. So the way to reconstruct is to prevent or to rebuild the stability between these two parts. The vectors can be divided into varus, which is contributed by the LCL, and the posterior and external rotation, which two of these combine to be posterolateral rotatory instability. And the main part will be the popliteus tendon and the popliteofibular ligament. To improve the result of the reconstruction, actually we have to get the comprehensive approach by preoperative assessment, surgical technique, rehabilitation protocol, and postoperative care outcome assessment. But due to the time limit, we will discuss about two first items. That is preoperative assessment and surgical technique. By preoperative assessment, we will perform physical examination, stress films, MRI, to get the correct diagnosis of the failed structure, which can be the primary or secondary restraints of the static stabilizers mentioned above. And don't forget to find out the associated lesions. Mostly will be PCL, ACL, meniscus, and cartilage. We must address this also. For the principle of the PLC reconstruction, the aim actually is to replace the vector and the footprint and claim to be anatomical. But really, anatomical or not, we'll discuss on this. And these are to replace the failed static stabilizers, not the dynamic stabilizers, which is the popliteus muscle. And essentially, these are the LCL, popliteus tendon, and popliteofibular ligament. And the other one is to choose the graft, which can be autograft, allograft. In our country, although we can have some of the allograft, most of them will be not that popularized. Most of them will use the autograft, which is the semi-T, gracilis peroneal longus, or plateau biceps femoris. And one of the most important things is to have the proper tension of the graft and proper fixation. And the other one is the surgical technique can be open, can be arthroscopy assisted, can be MIS. These are the details that I think we all can find out in the textbooks, in the literatures. For the principle of the reconstruction, as we restore the stabilities between the femur and tibia plus fibula, as I mentioned above. The key structures are the three things. The most popular technique, all of us have heard about Laplace. Everyone would say PLC will be Laplace. And because Laplace claimed that it is anatomically reconstructing the popliteus tendon from femur and tibia, and popliteofibular ligament from tibia and fibula, and LCL fibula to femur. Let's think about whether it is really anatomically or not. First of all, we look at the popliteus tendon. The popliteus tendon is passing from femur through the hiatus of the popliteal of the meniscus. There is a hole and biting popliteus tendon to the muscle below. And see, does popliteus tendon attach directly to the femur or not? Actually, the popliteus tendon doesn't attach directly to the tibia. There is some fascicles like anterior superior fascicle and posterior superior, posterior inferior fascicle of the popliteal meniscal fascicles that is attaches to the meniscus, and one attaches to the fibula, which is popliteal fibular ligament, but none of the part that is directly attaches to the tibia. So we cannot say this is the anatomical replacement of the popliteus tendon, because we do not fix from femur to tibia itself directly. And look at the popliteal fibular ligament. Popliteal fibular ligament actually it attaches from the popliteus tendon to the fibula, and when this is pulled, it will move in this direction. So popliteal fibular ligament is the connection actually between the femur and the fibula indirectly. So Laplace procedure replacing only popliteal tendon, popliteus tendon, and LCL. But for the popliteal fibular ligament, it combines between tibia and fibula. So it's not really the anatomical replacement of this ligament. So to have effect, the popliteal fibular ligament must join between the fibula and the femur itself. This is a fibular-based reconstruction. So look at the attachment of the structures at the fibular head. The popliteal fibular ligament is higher behind and posteromedially, while the LCL is more anterior. So there is modification of the fibular-based PLC reconstruction by aiming, instead of anterior to posterior like Larsen, they modified to the oblique direction, pointing more posteromedially. This is the modified Larsen reconstruction. We look at the attachment of the LCL and popliteus tendon. We know that when the knee is extended, the popliteus tendon will be more lower and behind. When it is flexed, it will be anterior and higher. And they have been measured that the LCL in extension and flexion, the LCL length will change, say, about 3 millimeters, while the popliteus tendon, when extended and flexed, the length will change for about 10 millimeters. So to fix the LCL, we can fix it in knee flexed position. But for the popliteus tendon, it should be fixed when it is nearly extended or about 30 degrees, and do not too much constrain it, too much tighten it. Otherwise, it will have some constraints of too much of the posterolateral tension. And there has been some investigation about the repressing. This is the tibial-based PLC or fibular-based PLC, and both of the tibial-based and fibular-based, the result is that only replacing the PFL of the fibular-based, the tension will be closely to about the normal or intact case of the posterolateral stability. So if we reconstruct too much of this, like adding two of the reconstruction technique, it will be too tight. And it will cause too much of the constraint. And there has been a systematic review say that there is no difference in clinical outcome of tibial-based versus fibular-based posterolateral coronary reconstruction. Anyway, there are so many types of the reconstruction techniques that we cannot say which one is best. But to improve the reconstruction, we have to know about what we are going to do. So some of them will replace tibial-based, fibular-based, and I myself, I have proposed a similar kind of reconstruction by using the bone washer technique. And some others, will replace three structures. One of them will replace quite similar to the popliteal fibular ligament by curving up the graft like this. This is replacing the tibial-based, and this is replacing fibular-based. This is quite similar to the natural posterolateral corner. And some of them will replace the fibular-based plus the part of the biceps tendon. And the other part has proposed the MIS LCL reconstruction using the partial biceps tendon harvested by the stripper of the biceps tendon to replace the lateral collateral ligament. And one other from Japan, they proposed that if the popliteal tendon and muscle are intact, replacing the LCL, we have the tail attached to the popliteal tendon. It's like to be the most anatomical reconstruction. But anyway, the take-home message is that there is no particular technique that is the best one. And everyone will be good if you can have good concerning about the choice of the graft, the tension, the vector, the footprint that you can place on it. And very importantly, to addressing also the associated injuries of the PCL, ACL, meniscus, and coronal lesions to make the stability of the posterior plus posterolateral corner instability. So this is my opinion, and thank you very much for the attention.